Today we are working with a young adult male who suffered from a left-sided stroke. He is now hypotonic in his right arm and experiences a lack of awareness in relation to body and position. He has speech function deficits and exhibits expressive aphasia and cognitive perceptual deficits. He shows frustration from other treatment sessions and has sternal precautions due to a cardiac incision, so it is important to not do any aggressive treatments that may injure this. From previous treatment sessions, we were able to observe Ben's performance skills, including enduring passive range of motion techniques, expressing emotion, handling a four-legged cane to ambulate with assistance, gripping the bed rail, and performing single-step actions introduced by the therapist. For our first neurorehabilitation technique, we are going to be using the PNF approach. It is used to address muscle tone and is based on normal movement and motor development. This meaning motor skills are developed progressively, gross motor movements patterns are performed before fine movements, and normal motor development proceeds proximal to distal. For our first intervention, we are going to be starting with D1 flexion. So we are starting in shoulder flexion, adduction, and external rotation. Our elbow can be in flexion or extension with our forearm supinated and our wrist flexed. Then coming into D1 extension, our shoulder will be extended, abducted, internally rotated. Our elbow can be in flexion or extension. Our forearm will be pronated and wrist extended. This technique is important for functional activities such as feeding, for the hand-to-mouth motions, and combing your hair on a certain side. It is imperative that the patient watches the hemiplegic side to increase sensory input. Our second intervention, we are going to be using NDT, also known as the Bobith approach. Our goal is to normalize tone, inhibit primitive patterns of movement, and facilitate normal movements. It is used to treat adult patients with hemiplegia and is geared toward encouraging the use of both sides of the body. Patients with hemiplegia often have deficits that can affect function, including diminished weight bearing on the hemiplegic side, sensory loss, and neglect and fear. Our primary concern during the examination are whether the patient exhibits good trunk control, whether the movement is free of abnormal muscle tone and synergies, and whether the movement is coordinated. So for our second intervention, we are going to be performing trunk rotation, and since I do not have a patient, I will just be demonstrating it on myself. But if I were to have a patient here, I would be performing this in 3 steps. The patient will be sitting due to mention of dizziness in previous treatments. So we will be reaching with the unaffected arm at a normal level height, and then a higher level, and then a lower level. So if I just demonstrated this right now, so for our left arm that is our unaffected, we would just be reaching to our normal light level, and then a little bit higher, and then to a lower level. Trunk rotation activities increase sensory input and improved awareness of the hemiplegic side. These are my 2 interventions for our neurorehabilitation techniques. Thank you.